Music intro.
Welcome to our explainer on benign paroxysmal positional vertigo, or BPPV. Today, we're really going to zero in on that crucial first step, taking a classic clinical history. Honestly, getting this part right is the absolute key to managing the most common cause of vertigo you will ever see.
So let's jump right in with a puzzle you've probably encountered. A patient comes in, they say they're constantly dizzy, but then they mention they feel perfectly fine the second they hold their head still. So what's going on? Is this BPPV? Well, the answer is actually hiding in the question itself.
But before we solve that puzzle, let's quickly talk about why recognizing BPPV is such a critical skill. Because this is a really common condition, but it's also, unfortunately, a huge missed opportunity for a simple, effective treatment.
You know, we're not talking about some rare, obscure condition here. BPPV is, plain and simple, the single most common cause of that true, room-spinning vertigo that's going to walk through your clinic door.
And just look at the scale of this. While about 2.4% of people will have it at some point in their lives, it's way more common in clinical practice. It can account for up to 30% of all dizziness in primary care and a whopping half of all vertigo cases in specialist clinics.
But here's the real kicker. Even though BPV is so treatable, the data shows that fewer than 10% of patients who are eligible in primary care are actually offered the definitive treatment, which is just a simple repositioning maneuver.
And you know, closing this gap is about so much more than just treating dizziness. For our older patients, identifying and treating BPPV is a powerful, high-impact falls prevention strategy. It's a major risk factor that we can fix, often in a single consultation.
Okay, so let's get into the mechanics of BPPV. Once you understand how it works, recognizing the classic symptoms becomes a whole lot easier. So the culprits here are these tiny calcium carbonate crystals called Otoconia. The easiest way to think of them is as microscopic rocks. Now, they're supposed to live in one specific part of the inner ear, but in BPPV they break loose and end up rattling around in the wrong part of the inner ear's plumbing.
It's basically a three-step process. First, the crystals get dislodged. Second, when you move your head, gravity pulls these loose crystals through one of the semicircular canals. And third, that movement creates a flow of fluid that sends a powerful but completely false signal to your brain that you're spinning.
And here's a key detail. In about 80 to 90% of all cases, these crystals end up in the posterior semicircular canal. Why? Well, it's just the most gravity-dependent part of the system, so that's where debris tends to collect. This is a really important anatomical clue that's going to guide our diagnosis later on.
So, now that we know the mechanism, it's basically loose rocks moving with gravity. We can build a classic suspect profile just by listening carefully to our patient's story.
An experienced clinician can get incredibly confident about a BPPV diagnosis just from these 5 signature features. The attacks are short, just seconds long. They're always brought on by specific change in position. The patient feels totally normal between attacks, and, this is crucial, there are no hearing or neurological symptoms at all.
Okay, but what about our patient from the beginning? The one who insisted their dizziness was constant. This is where one simple, clarifying question can unlock the whole diagnosis.
See, patients will often describe their symptoms as constant because every little head movement they make keeps re-triggering these brief attacks. So from their perspective, it feels constant. Asking this one question helps you and the patient differentiate the short, sharp attacks of BPPV from a true continuous vertigo. It's a real game changer.
Now, knowing what BPV is means you also have to know what it isn't. So let's quickly go over some of the red flags in the history that should make you think about other diagnoses.
This comparison is so important. If the vertigo is lasting minutes to hours, that's not BPPV. You should be thinking about things like vestibular migraine or Meniere's disease. If there's hearing loss, well, that points you towards something like labyrinthitis. And of course, any neurological symptoms like double vision or weakness should make you immediately suspicious of a central cause, something going on in the brain itself.
So let's bring it all home. Why have we spent so much time just focusing on the patient's story? Because for BPPV, the history is your single most powerful diagnostic tool.
Think about this. When you take a really careful history, you can narrow the diagnosis down to BPPV in over 80% of cases. That's before you've even laid a hand on the patient or done a single physical exam maneuver.
To put it as simply as possible, BPV is a diagnosis you make by listening. Your ears are, without a doubt, your most powerful and efficient diagnostic tool for this condition.
Okay, so now you can confidently suspect BPV just based on the history.
The next logical step is to confirm it. So please join us in the next explainer, where we're going to move from the chair to the examination couch and really master the diagnostic maneuvers, the Dix-Hallpike, and the supine roll tests.
Thanks so much for watching. If you want to explore more topics on dizziness, vertigo, and imbalance, or get access to more resources for clinicians and patients, please come and visit our website.